Now, from today onwards, we will talk about certain abnormal condition during pregnancy, certain disorders during pregnancy, like hypertension in pregnancy. This is very important topic, so we are going to talk that in today's class. And after that, maybe anemia during pregnancy, okay, jaundice during pregnancy, then RH isoimmunization or RH incompatibility during pregnancy, okay, and so many other topics are there, like multiple pregnancies are there, okay, different types. So we'll talk one after other. Let's move on. Obstetrical complication, and the first topic for us is hypertension in pregnancy or during pregnancy. Now, in the beginning, okay, we all know the definition of hypertension. So let's define hypertension generally. What is the definition? Yes? Anyone? General.
So generally, sir, hypertension, we have like, sir, we have
Yes.
like, sir, the blood pressure above that normal rate. Like, sir, for example, like, sir, we have normally
increase in BP than normal.
Now, sir, above that range is if you've got we have blood pressure, you call it hypertension, sir.
Okay.
Blood pressure in the arteries is
Hypertension is blood pressure more than normal, systolic more than 140 and diastolic more than 90.
Okay. Now, most of the students are answering correctly, though some are a bit of vague answer, but I already got the answer here. You can say hypertension is raised blood pressure in a sustained level. It is a sustained rise in blood pressure. The term sustained is important there. Otherwise, we call it transient rise, and that is not, that is still called hypertension, but it's not clinically very important because after a few hours, the person will come back to the normal. In this case, we are talking about a bit long-term type of rise in blood pressure. So sustained increase in blood pressure, more than 140 systolic and more than 90 diastolic is called hypertension. So this is a very basic definition. And if you give this definition, nobody can ignore your answer. Though there are so many different classifications, but this is the very basic thing. Now let's come to the pregnant condition. Hypertension during pregnancy, okay, is classified by American College of Obstetrician and Gynecologist into 4 types. They have classified or described this under 4 types. So let me talk about what are those 4 types now. One is gestational hypertension. Another is pre-eclampsia and eclampsia syndrome. Third, chronic hypertension of any etiology. And fourth, pre-eclampsia superimposed on chronic hypertension. Now, this whole class is about these different types. But let me clarify right now so that you have a very clear vision when you move further. Now, gestational is a term for pregnancy. So this is hypertension during pregnancy. Okay. So this is evidence for the pre-eclampsia syndrome doesn't develop and hypertension resolves by 12 weeks postpartum. This is gestational hypertension. So what is the meaning? Here, pre-eclampsia, criteria doesn't fit. There is just a rise in blood pressure, okay, during pregnancy. And it will resolve 12 weeks after the birth of the baby. Postpartum means after the birth. That is the meaning. Preeclampsia and eclampsia are a very serious condition. There is increase in blood pressure after 20 weeks of gestation. Okay, after 20 weeks of gestation, and preeclampsia is associated with proteinuria with some other symptom. We'll talk about that. Whereas eclampsia is preeclampsia with seizure disorder. The person will develop grand mal seizure in case of eclampsia. And here we are talking about the pregnancy, so that pregnant lady will develop seizure, that is called grand mal seizure, along with rise in blood pressure after 20 weeks of gestation. This is eclampsia. Third is chronic hypertension of any etiology. What is the meaning? The lady was hypertensive from before. Okay, prior to pregnancy, she was already hypertensive. So that same hypertension is continued during pregnancy. That is called chronic hypertension. And the fourth one, okay, she is already a hypertensive case. Okay, she is already a hypertensive case, but on top of that, she develops preeclampsia. So this is called, superimposed case of preeclampsia on chronic hypertension. Let's move on. Now, look at the definition here. Chronic hypertension is a systolic blood pressure more than 140 millimeter of mercury, or diastolic blood pressure more than or equal to 90 millimeter of mercury prior to pregnancy, prior to 20 weeks of gestation, or persisting longer than 12 weeks postpartum. Just remember one term here. The lady was hypertensive from before she became pregnant. And the same process continued during pregnancy and even after the delivery of the baby. This is called chronic hypertension. Gestational hypertension, the same criteria. Systolic blood pressure more than 140 millimeter mercury, or diastolic blood pressure equal to or more than 90 after 20 weeks without proteinuria. Let me underline this very important term, without proteinuria. If there is proteinuria, we call it preeclampsia. So it will go into preeclampsia now. Now, what is this preeclampsia all about? Please pay attention. This is a very important question in the obstetrics exam. Now, preeclampsia is a type of hypertensive disorder during pregnancy. There is no doubt about it. This is a new onset hypertension with or without proteinuria more than 20 weeks gestation. Now, don't get confused here. It is written without proteinuria. Some of the textbooks, some of the author, or some of the obstetricians believe preeclampsia can occur even without proteinuria if there are some other symptom. So when we go through this slide, it will be very clear to you. Okay, this is definitely new onset hypertension. The lady usually develop hypertension after 20 weeks of gestation. Now, there are different types now. One is non-severe preeclampsia. What do you mean by that? Okay, non-severe preeclampsia here. That means systolic blood pressure more than 140, or diastolic more than 90, and proteinuria is more than or equal to 300 milligram in 24 hours. Or if we do dipstick urine test, it is 1 plus. Or if we do protein creatinine ratio in the urine, it is more than or equal to 0.3. Now, I'm not sure whether you know these things or not, okay? But let me clarify this once again. Proteinuria, this is judged by the routine urine test or routine urine analysis. When we send a urine sample to the lab, this is called routine urine analysis. They will check what is the total protein there, what is the total glucose there, okay? Are there any WBCs present or not? If present, how many are there? They count that also, different type of things. So when they do the protein, assessment or estimation, it is more than 300 milligram in 24 hours for the criteria to fulfill. Or another way these days is even easier. This is called dipstick urine test. They are already preformed strip. They just soak that strip in the sample of urine, and it changes according to the amount of protein present there into different color. So 1 plus urine dipstick is enough for the criteria of non-severe preeclampsia. The third one is called protein creatinine ratio or PC ratio. This is very commonly done in the diagnosis of nephrotic syndrome. Okay, nephrotic syndrome. In nephrotic syndrome, the PC ratio is more than 2. But in this case, because of less proteinuria, the ratio is enough if it is more than 0.3 or equal to 0.3. So these are the different things. What about severe preeclampsia now? The amount of blood pressure rise is more here. See this? Systolic blood pressure is more than, okay, or equal to 160. Diastolic blood pressure is more than or equal to 110. So this is definitely severe. Apart from this, proteinuria is also high. See this? More than or equal to 5 gram in 24 hours now. This is too much proteinuria. If we do dipstick test, it is 3 plus, whereas it was 1 plus in the non-severe one. Apart from that, there are so many other symptoms because multiple organs may be damaged by the severe hypertension, and they are oliguria of less than 500 ml in 24 hours. Symptoms like headache, visual change or blurring of the vision, difficulty breathing, and right upper quadrant pain, elevated liver enzyme, and low platelet. Okay, these are very important points. So let me clarify these one by one for you. Oliguria means kidneys are involved. Probably kidneys are not functioning properly as a result of a sudden increase in blood pressure. Headache and visual change. How can we explain that in connection with hypertension? Anybody? What is the cause of headache and visual change if blood pressure is very high? Who can answer this?
Sir, in hypertension, when arteries pressure is increased and they pass through the cranial skull holes, and there is dura receptors which stretch on increased pressure and produce headache.
Okay, fine.
Sometimes
Anybody?
thrombic headache.
Okay. Anybody else? Anybody wants to say here something? Now, remember, headache is a very common feature of hypertension. Very common feature. Usually, when our pressure becomes high, occipital headache occurs. Occipital. But hypertension can lead to hypertensive encephalopathy. That is an important term. Hypertensive encephalopathy. There is cerebral edema development. There is increased pressure inside the cranial cavity, and that can also lead to headache, as well as visual change. When the pressure inside the cranial cavity increases because of cerebral edema, because of hypertensive encephalopathy, the person may develop papilledema, and that papilledema may lead to visual change. Now, the same type of mechanism can cause pulmonary edema or heart failure also. Usually the left-sided heart failure, there is fluid collection in the lung, which result in difficulty to breathe. Okay, this is a feature of pulmonary edema. And inside the liver, the person will suffer from HELLP syndrome. I'm not sure whether you have heard this term before or not. It is known as HELLP syndrome. Now, what is the meaning? HELLP syndrome means H stands for hemolysis. Hemolysis. Okay. E and L stands for elevated liver enzyme. Elevated liver enzyme. Let me write in the short form here. Elevated liver enzymes. And the last one, LP, is for low platelet count. Very good. Low platelet count. So in this topic, we are going to talk about this, many times. Okay. This is important knowledge for you. Let me, shift it here so that you can clearly see it. So HELLP syndrome, hemolysis, elevated liver enzyme, and low platelet. Now let's come back to our slide here. What is written? Right upper quadrant pain. This is because of swelling of the liver. This is because of stretching of the glycan capsule after swelling of the liver. This can occur in HELLP syndrome, or this can also occur because of heart failure. Elevated liver enzyme like SGOT and SGPT, they are high, or ALT and AST are high, and low platelet. When platelet counts is less than 100,000 or 1 lakh, okay, we call it low platelet. So all of these are features of severe preeclampsia. Now, preeclampsia can deteriorate into eclampsia also. it can deteriorate into eclampsia. Means the same lady can develop seizure, grand mal seizure. This is eclampsia. And some of the new guidelines do not use proteinuria to rule out preeclampsia these days. Okay, so these are some of the very, very important. If a pregnant lady develops a new onset hypertension after 20 weeks of gestation with thrombocytopenia that is less than 100,000, or you can call it 1 lakh also per microliter, or a serum creatinine value more than 1.1, okay, or there is elevated liver function test, especially the liver function, enzyme like SGOT and SGPT, 2 times the upper limit of normal, or if there is presence of pulmonary edema or cerebral or visual symptom. These are known as different symptoms of preeclampsia. Then also the definition is fulfilled. Now, another is chronic hypertension with superimposed preeclampsia. Very easy to understand. What is the meaning here? The lady was already hypertensive prior to pregnancy. On top of that, there is a new disease emerged during pregnancy, and that is preeclampsia. The blood pressure further shoots up after preeclampsia and a lot of complication. Along with that, there is proteinuria as well. All blood pressure should be taken on 2 occasions, 4 hours apart, after the patient has been seated quietly for several minutes, and cough should be at the level of the heart. Now, this is how we take blood pressure. I'm sure in internal medicine practical, you will learn how to take blood pressure, okay? And many of the students, they have already learned probably in physiology. Now, we should take at least 2 readings, okay, at least 2 readings, and there should be a considerable gap, at least 5 minutes in the normal clinical practice. But this is a special type of case, and usually this type of people are admitted in the hospital, so taking blood pressure 4 hours apart is not that difficult for us. Okay, so this is the procedure. HELLP syndrome, we already talked about. Hemolytic anemia, elevated liver enzyme, and low platelet. This is a combination of 3 things together. And this is considered as one of the complications of preeclampsia. Eclampsia is preeclampsia with seizure. That seizure is a generalized tonic-clonic type of seizure, which is also known as grand mal seizure. So let me write that term here for you, okay, because it is important one. Grand mal seizure. Okay, so this is a generalized tonic-clonic type of seizure. We call it GTCS, generalized tonic-clonic seizure. So this is seen in eclampsia. Let's move on. Now, all of you, please focus on these 2 slides which we have included here. It is like revision for you till this slide. Whatever you have learned in this topic are revised once again, because these are absolutely important definitions which are asked in the Viva exam or wherever you go for your clinical exam. Preeclampsia, after 20 weeks of gestation, this is very important term. After 20 weeks of gestation, systolic blood pressure, if it is equal to or more than 140 millimeter mercury, or diastolic blood pressure equal or more than 90 millimeter mercury in a previously normotensive woman. She should not be hypertensive from before. She has to develop new hypertension. That is also after 20 weeks of gestation. Proteinuria, that is excretion of more than or equal to 0.3 gram of protein in a 24-hour urine collection sample, or with other systemic manifestations like headache, blurring of the vision, difficulty to breathe, tender right upper quadrant, oliguria. All of these are other systemic manifestations. Then it is a case of preeclampsia. This is the meaning. Okay. See that. It's a case of preeclampsia. And these are all the different criteria. Now, gestational hypertension simply means elevated blood pressure that is more than 140 or equal systolic and more than or equal 90 diastolic after 20 weeks of gestation in a previously normotensive woman without proteinuria and other systemic manifestation. This is known as gestational hypertension. Just remember, simply blood pressure become higher than the normal without any other thing. Okay, that is the meaning. Whereas, okay, chronic hypertension means the lady is hypertensive from before. Now see this. Systolic blood pressure more than 140 and diastolic more than or equal to 90 before pregnancy or before 20 weeks of gestation. This is called chronic hypertension. This is also quite clear. And then chronic hypertension with superimposed preeclampsia. Now, what is the meaning? New onset of proteinuria in the setting of hypertension before 20 weeks of gestation. That is known as superimposed preeclampsia on top of chronic hypertension. And this is a complicated situation because the lady was already hypertensive from before. On top of that, the blood pressure further increases because of preeclampsia and more chance of other complications as well. One of that is HELLP syndrome. Let's move on. Now, I'm going to skip this. This is also saying the same thing. Now, see there, gestational hypertension. This is the definition. And preeclampsia. These are the different criteria for preeclampsia. Proteinuria, thrombocytopenia or decreased platelet count, renal insufficiency or renal failure, liver involvement, which is a part of HELLP syndrome, cerebral symptom like headache, visual disturbances or seizure, and pulmonary edema results in breathing difficulty. So these all are part of preeclampsia or pregnancy-induced hypertension. Now, what are the overall symptoms of preeclampsia? This is again a type of repeat slide for you. Okay, many of the things I've already explained before. So just pay attention here and try to retain something in this class. First is high blood pressure, definitely. More than or equal to 140 systolic and more than or equal to 90 diastolic. Second is proteinuria or additional signs of kidney problem. Now, what do you mean by that additional sign of kidney problem? Yes. What other? Anyone?
Like polycystic kidney disease, pyelonephritis.
Severe kidney pain like colics are in kidney.
Okay, but here you are right. If I ask that general question, your answer is absolutely correct. Okay, but in this case, in preeclampsia, what other kidney problem may happen to that lady? Okay, what is that? Renal failure. Renal failure or kidney failure results in oliguria. Oliguria. Okay, and after oliguria occurs, serum creatinine level will be higher. That is so easy to remember. So that is meaning of additional sign of kidney problem. Severe headache. Okay, we already explained this because of raised intracranial pressure. Changes in vision, including temporary loss of vision, blurring of the vision, or light sensitivity, and most of these are associated with papilledema. Okay, they are associated with papilledema. Now, see here, papilledema. What is papilledema? So let me explain this. I'm sure you have heard this term before. Papilledema is swelling of the optic nerve head, okay, or optic disc. This is the swelling or edema of that part. It is strongly associated with raised intracranial pressure. The optic nerve is a second cranial nerve, and we consider this as a direct extension of the brain itself. What do you mean by that? It is covered by the same meninges which cover the brain as well as spinal cord. So whatever pressure is elevated inside the cranial cavity, that pressure is reflected onto the retina through optic nerve. And that's why papilledema occurs. Remember this, never forget. A papilledema may be seen in this condition as well. There are so many other causes of papilledema. If your teacher asks, like meningitis, encephalitis, brain abscess, cerebral malaria, brain tumor, neurocysticercosis, any bleeding inside the cranial cavity, because all of them are associated with increased intracranial pressure. Let's move on. Another one is pain in right upper quadrant. Now, this is because of congestion of the liver. Hepatic congestion will give pain in upper right abdomen. Difficulty to breathe because of pulmonary edema, which may be one of the problem. Eclampsia may result because of preeclampsia. So if eclampsia occur, the lady develops seizure. This is grand mal seizure, okay, or generalized tonic-clonic seizure. She may develop nausea or vomiting and low urine output. These are features we already talked about. If HELLP syndrome occurs, okay, she may also have bleeding or bruising easily. She develop extreme fatigability, impaired liver function, and thrombocytopenia. Now, this extreme fatigability is a feature of hemolytic anemia. We all know in anemia, the person becomes excessively tired or fatigued. Impaired liver function means raised liver enzyme, and thrombocytopenia. These three, okay, are the part of HELLP syndrome. At the same time, because liver is damaged and the function of liver is production of certain coagulation factors, so there is a chance of bleeding or bruising easily. This is known as coagulopathy. Coagulopathy. Okay, no need of an explanation. You already know these things. I'm just, bringing everything together here. And then remember, this is a preeclampsia. Okay, so because of involvement of the kidney, there is sudden weight gain and edema appearance in the body. But this is a case of pregnancy. So in pregnancy also, there is already a weight gain and edema. So these are considered not very reliable signs of preeclampsia. Okay? But one important point, if you take a very good history, and if the lady clearly say, doctor, I was not like that before. Okay, prior to 1 or 2 weeks, I was not like that. And these things have recently started. And if that duration is after the 20 weeks of gestation, then probably it is caused by preeclampsia. So this is the way we reach to the conclusion. Now this table, okay, is again highlighting what are the features of preeclampsia. See that? These are the different way of revising ourselves in the class. So please pay attention. You will be so clear after I finish this lecture. Severe headache, visual disturbance like flashing of the light or blurring of the vision, vomiting, subcostal pain. This is also known as right hypochondrial pain, okay, because liver is congested there. Papilledema, that's what I was talking just now. Clonus. Anybody know what is clonus? That may be a new term for you. Yes? Anyone?
Yes, sir.
So it is an involuntary muscle contraction.
So it is neurological condition in which there is it's an involuntary muscle like uncontrollable rhythmic and like some movement, shaking movements are there will be.
Okay.
Involuntary muscle contraction.
Good.
It
good.
is a cause of lion in upper motor neuron.
Very good. So you already have the concept. Excellent. I'm very happy because still, the central nervous system was not discussed with your batch, but still you have this concept. Wonderful. Now listen here. Clonus is called exaggerated reflex. So it is done in the same way we elicit reflexes, but procedure is slightly different. Now there are two types of clonus we talk about. Okay, patellar clonus and ankle clonus. Now patellar clonus means you just catch the patella with thumb and your index finger and push it upwards. You catch it and quickly press or push it upward. If you do that, the knee okay, will oscillate for so many times. It keep on oscillating. And this is known as patellar clonus, because there is a twitching type of movement of quadriceps femoris muscle. Whereas ankle clonus you catch the ankle joint, okay, and quickly dorsiflex it. Quickly dorsiflex it upward. And if you do that, the ankle joint keep on oscillating for more than 4 or 5 times, or sometimes even more than that. That is called clonus, and it is commonly seen in upper motor neuron lesion. Now, what is the connection? I'm talking about preeclampsia now, okay? And right now, we are talking about clonus. The connection is very easy. Remember what happens to the brain because of preeclampsia. There is hypertensive encephalopathy. In case of eclampsia, there is seizure development, and all of these can result in damage to our brain. This is called upper motor neuron lesion. Okay. Now, liver tenderness, already talked about. Thrombocytopenia, already talked about. Less than 100,000, okay, per cubic milliliter. Abnormal liver enzyme like aspartate transaminase or alanine transaminase, if they are more than 70 international unit per liter, this is per liter, okay. And HELLP syndrome, hemolysis, elevated liver enzyme, and low platelet. Now you can always write something if this question comes. Now let's move further. Let's talk about one very less risky condition, which is known as transient obstetrical hypertension. This is a transient phenomena. What is the meaning? Here, the blood pressure is definitely higher than the normal. Okay, that is more than 140 over 90 systolic and diastolic. But blood pressure elevation is not sustained. It is a transient phenomena. That means it returns to the baseline after a transient period of observation or after the patient takes rest. This is transient obstetrical hypertension. I can compare this with, okay, another feature known as white coat hypertension, which I'm sure you have heard in medicine. White coat hypertension. When the patient goes in front of the doctor, okay, because of the agitation, because of the anxiety, because of sympathetic stimulation, there is rise in blood pressure. But after certain time, blood pressure would be normal. A similar type of situation here. Okay, not exact. Okay, I'm not saying it is the exact situation, but I'm comparing. That is also transient, and this is also transient. But this particular situation occurs during pregnancy. Here, proteinuria is absent, and the presenting symptoms and physical examination finding would be there are no symptoms of preeclampsia seen, like there is no headache, no epigastric pain or hypochondriac pain, and there should not be any visual disturbances. And physical findings are unremarkable for pregnancy. There are no extra other findings. So this is transient obstetrical hypertension. Now, lab abnormality, unremarkable. Proteinuria is also absent. Okay, no lab findings are positive here. And diagnostic test, there are no pathognomonic tests. And the key finding is just the rise in blood pressure, which rapidly returns to the baseline on the repeat measurement. So if somebody asks you, what are the problem of this transient obstetrical hypertension? The answer is they do not cause any problem to the lady. Okay. Now, what is the management then? Conservative outpatient management is done. We don't need to admit. Just diagnosis is important here. But some of the appropriate lab tests should be performed just to rule out whether this is a case of preeclampsia or not. Just to make sure, from your side. If it is preeclampsia, then probably we should admit her and we should, start the treatment. Differential diagnosis is preeclampsia, which should be ruled out. So this is a transient obstetrical hypertension. Let's enter into the gestational hypertension. That is the hypertension in pregnancy. All these different things which you have studied till now, like preeclampsia, eclampsia, all these are gestational type of hypertension. Okay, but there is a difference between gestational hypertension as such and preeclampsia, and that is it occurs without proteinuria, and preeclampsia, eclampsia, and those things occur with proteinuria, with a lot of clinical symptoms and sign, and with a lot of lab, reports. I'm making it very simple right now. So at the end, when we solve this type of different clinical scenario, it will be easy for you. Now let's come to the topic. Gestational hypertension means it's a sustained elevation of blood pressure in pregnancy, more than 140/90 after 20 weeks without proteinuria. And BP returns to normal in postpartum period. After giving birth, blood pressure will fall back to the normal. Regarding the presenting symptoms and physical examination finding, there are no symptoms of preeclampsia seen here, like headache, gastric pain, visual disturbance. This should be absent. And other physical findings are unremarkable. Regarding the lab abnormality, lab tests are unremarkable. Proteinuria is absent. If it is present, we don't call it gestational hypertension per se. We call it preeclampsia. And the diagnostic test is very simple. Just measure the blood pressure and do the urine test. Urine test should show no proteinuria. Blood pressure should be higher. That's it. What is the management? Look at the management here. It's a conservative outpatient management again. Close observation should be done. Sometimes the blood pressure may be a little bit higher, so close observation is necessary. One problem lies here. 30% of the patient will develop preeclampsia from this situation. So that's all. For this reason also, close observation is necessary. Appropriate lab testing should be performed to rule out preeclampsia. Otherwise, for the diagnosis of gestational hypertension itself, we don't need any other investigation. Okay. Now, regarding the differential diagnosis, preeclampsia is the strong differential diagnosis which should always be ruled out. Now, I'm moving into the very important part of this lecture. Okay, though in the beginning of this class, I clearly listed this mild preeclampsia and severe preeclampsia. Now, let's talk about them in little bit, detail. What is the pathophysiology? What is maybe the etiology? Okay, and how we reach to the diagnosis. The definition of mild preeclampsia is sustained blood pressure elevation in pregnancy after 20 weeks of gestation. This is very, very essential. Without this, I cannot enter into the definition at all. In the absence of pre-existing hypertension, a lady should not be hypertensive from the beginning. Now, what else we need for the diagnosis? There are no pathognomonic tests. Now, what do you mean by pathognomonic test? Anybody? What do you mean by that, Tom?
Sir, a pathognomic test, sir, it is a characteristic for that particular disease, sir. It is that sort of a test, sir.
Very good. Excellently, described. Excellent. Now, there are certain diseases, and certain tests. And if that test is positive, we always think about that disease. Always. Like, I can give you certain, example for you here. Like Reed-Sternberg cell. Reed-Sternberg cell is associated with Hodgkin's lymphoma. Anti-double-stranded DNA, it is associated with SLE. Like these are the certain examples, So if those things are there, then we almost confirm, yes, that disease is present in the patient. So there are no pathognomonic tests to make sure that this is a case of preeclampsia. But never mind, we have so many other, features. Like here, this diagnostic triad we can use, which include sustained blood pressure elevation of more than or equal to 140/90, proteinuria and dipstick of 1 to 2 plus, or if you analyze the urine for 24 hours, then more than or equal to 300 milligram, and edema of the face or upper extremity. So this is known as diagnostic triad of mild preeclampsia. Now, what are the risk factors? Okay, what are the risk factors which have a high chance of developing into preeclampsia in that particular pregnancy? Preeclampsia is found 8 times more frequently in primipara, 8 times more frequently in primipara than in multipara. So this is a very important risk factor itself. And we all know what is primipara, isn't it? What is primipara? Yes?
First time pregnancy.
Lady which is pregnant for first time.
Is
So
it?
the first time pregnancy is
After the
sir, after the period of viability.
after the period of viability, 20 weeks of gestation.
Exactly. Now your definition is complete. If you just say the lady is pregnant for the first time, this is called primigravida. Okay. But if you say, yes, she is pregnant for the first time and she has crossed the period of viability, she is primipara. Excellent. So the chance is very higher. Other important risk factors apart from that, okay, are, see here, multiple gestation means twin pregnancy, triplet, quadruplet means more than one baby inside. Hydatitiform mole. Hydatitiform mole. This is also known as molar pregnancy. And this is a very interesting type of situation where a faulty ova is fertilized by the sperm. Okay. And then there are 2 types of hydatitiform mole: incomplete mole and complete mole. Incomplete mole, there is no fetal tissue at all. It is all replaced by the molar tissue. We'll talk about this. This is special class. Diabetes mellitus. Age extreme, less than 18 year and more than 35 year is called extreme age during obstetrics. Remember that. Less than 18 year, if somebody is pregnant, we call that young mother, and more than 35 year old mother, because they have high chance of complication. Chronic hypertension, chronic renal disease, family history of preeclampsia, obesity, and hypercoagulability. If these things are present, then there is higher chance of development of preeclampsia in that lady. That is the meaning. Now, can you give one example of hypercoagulable condition? Any one example, anything.
The DIC.
Hemophilia, antiphospholipid syndrome.
Okay, thrombophilia or antiphospholipid syndrome. Now DIC, DIC is rather, a bleeding disorder rather than hypercoagulable condition. But I cannot completely ignore his answer also, because in DIC 2 types of mechanism are going side by side. In certain parts of the body there is extensive thrombosis going on. In other parts of the body, because of the utilization of the clotting factor, there is bleeding. So DIC, you better answer it as a bleeding complication. Okay. So
what about hemophilia? Also bleeding disorders also.
Dysfibrinogenemia.
Hemophilia,
now wait. This is a situation where there is extensive thrombus formation in the body. This is known as hypercoagulable condition, thrombosis condition. Okay. So thrombophilia, when thrombus or the thrombocyte or platelets are in excessive number. Okay. Think about those situation. And antiphospholipid syndrome is one of the condition where extensive thrombosis occurs throughout the body. So these are the good example. Now let's move further. What is the etiology or pathophysiology of this mild preeclampsia? What is happening inside the placenta? Pathophysiology involves, see this, diffuse vasospasm caused by relative or absolute changes in the following prostaglandin substance. Now, there are 2 types of prostaglandin substance which are abnormal here. One is thromboxane and another is prostacyclin. Now, thromboxane is a vasoconstrictor type of prostaglandin, whereas prostacyclin is a vasodilator type. So there is a clear-cut imbalance between these here. And what is that imbalance? Thromboxane amount is increased, whereas prostacyclin is decreased. So that there is excessive vasospasm in these conditions. Okay? And that excessive vasospasm can result in decreased blood flow towards the baby and decrease blood flow to the different other organ and rise in blood pressure. Now, this vasospasm contributes to intravascular volume constriction and decreased perfusion of most organ, including uteroplacental unit, kidney, liver, brain, and the heart. It is not only restricted to the placenta or uterus, it is also in other organ. So this is the big problem here. That's why this hypertension is damaging the brain, liver, kidney, and even the heart. Decreased renal blood flow leads to decreased clearance of body metabolic waste. This is known as renal failure. That's why there is increased creatinine level in the blood. That's why the lady suffers from oliguria. And capillary injury is a very important pathophysiology in this case. This capillary injury occurs throughout the body, which leads to loss of intravascular volume into the interstitial space and subsequently developing edema. Okay, so you can also call it leakage of the capillary fluid that occurs because of increase in blood pressure again. Now, please mute yourself. See this slide. It is clearly telling us there is a increased level of thromboxane A2, increased level of thromboxane A2, and decreased level of prostacyclin. That's the imbalance because thromboxane A2 is the vasoconstrictor substance, prostacyclin is a vasodilator substance. Okay, so this blood vessel will become like this, and naturally it will cause increase in blood pressure because there is increased peripheral resistance now, and blood pressure is all about the multiplication of cardiac output by peripheral resistance. If cardiac output is more, blood pressure is more. If peripheral resistance is more, blood pressure is again more. Now, what are the symptoms and physical examination finding of mild preeclampsia? You already talked about this, okay? It is again like a revision for you. There would be excess weight gain and fluid retention. Now, the normal pregnancy also will have excessive weight gain and fluid retention. This is considered normal things during pregnancy, but in this situation, this is excessive. There is a presence of new onset of persistent headache, epigastric pain, and visual disturbance. Okay. Now, if these are present, then we think about severe type of preeclampsia rather than mild. But sometimes, it is a in-between type of condition. Some of the features are present even in mild to moderate type of preeclampsia. And if all of them are present, then we can think of severe preeclampsia. So medicine is always like that. There is never 100% of the thing, whatever you have studied in the textbook, you can never see all of those things in the patient. So this is the importance of having practical knowledge. Yes, you can be a very good doctor by having good theoretical knowledge, but you should know how to implement that in the patient. That you don't know. Okay, if you don't go to the hospital, if you don't examine any patient, you don't know that. Okay, but there is a lot of time left for you to do those things. But before you go to and check those patients, you should have a head knowledge. What are the things I should know? What are the things I should ask to the patient? How we examine that what you are learning right now. Now, what are the lab abnormality that can occur in milder type of preeclampsia? There may be evidence of hemoconcentration, and that is shown by elevation of hemoglobin, hematocrit, blood urea nitrogen, serum creatinine, and serum uric acid. Now, let me ask one simple question to you. Why hemoconcentration occurs in this case? Means why hematocrit is higher than normal? Why? Anybody? Yes?
Because of decreased kidney function.
Because of decreased kidney function. Good. Okay. Any other answer? Any other?
Sir, in this in pre-eclampsia, sir, there is a chance of the renal failure high, and there will be a high level of the erythropoietin maybe, and lead to hemoconcentration.
Okay. So he's trying to correlate the things. Okay. Very good. Okay. That's the type of thinking you should develop. But remember, if kidneys are damaged, erythropoietin is not increase, isn't it? It is decrease, right? It is decrease. So it is not matching your explanation here. Okay, but that is a very good way of thinking. That is the way you should develop in medicine. Excellent. Now listen here. What I just told you, there is diffuse capillary damage in case of preeclampsia, and after these capillaries are damaged, there is leakage of the fluid, but the blood cells are not leaked outside. That results in hemoconcentration. This is known as relative increase in hemoglobin and hematocrit, not a real increase. Okay, fluid is getting outside the blood vessel, but blood cells are still there. So this is a relative type of thing. Now, this is a case of hypovolemia. Remember, though the person is edematous, why I am using the term hypovolemia here? Because the amount of fluid present inside the arteries is already less. And that what matters for us, the intra-arterial blood volume. And if that is less, kidney will get decreased blood flow. Okay, the waste products cannot be excreted outside, and all these things happen. Proteinuria is described under the diagnostic test. It is very important, necessary, and we always do this. And there may be evidence of DIC or liver enzyme elevation. Now, if they are present, we call it severe type of preeclampsia rather than milder type.
Now, with this, let's move on. What is the management of mild preeclampsia? Let's talk about this. See there. Now, the only definitive cure of mild preeclampsia is delivery. So we deliver the baby if we can deliver. Now, sometimes we cannot deliver the baby. For example, if it is a very premature baby, okay, then we need to go for conservative type of management. But if the baby has already crossed 34 weeks of gestation, lungs are already mature enough, okay, then we can do this type of decision. Removal of all fetal placental tissue will cure a preeclampsia. So this is a very good point to know. Now, however, delivery may be deferred in mild preeclampsia to minimize neonatal complication of prematurity. That's what I told just now. It depends. What is the gestational age? Do not deliver the baby in very premature period because lungs are not mature enough and the baby will have so many complications after the birth. So conservative inpatient management would be before 36 weeks of gestation, as long as the mother and fetus are stable, mild preeclampsia is managed in the hospital, watching for possible progression to severe preeclampsia. This is known as conservative management. See this. So what are the important points we should know? Before 36 weeks of gestation, as long as the mother and fetus are stable, we can go for wait and watch type of management. That is called conservative inpatient treatment. No anti-hypertensive agent or magnesium sulfate are used during this time. Just wait and watch because blood pressure is not that very severely high. And after 36 weeks of gestation, okay, we can deliver. We can deliver the baby. So that is indicated with dilute IV oxytocin induction of labor and continuous infusion of magnesium sulfate to prevent the eclamptic seizure. Now, magnesium sulfate is important drug in this situation, but oxytocin is used to induce the labor. So these are two different type of medicine. Let's move on. Now, we are going to the important part. What problems can preeclampsia cause? Why preeclampsia is a serious situation? What can happen to the mother and the baby? Now, abruptio placenta can occur because of preeclampsia. So please mute yourself. What is abruptio placentae? Yes?
Sir, abruptio placenta, sir, when the
The
placenta
placenta separate from the
Rupture
uterine wall
and
before
placenta is
delivery.
separate from the
Before the transit of labor.
so that separates the prematurely, sir, causing excessive bleeding.
Exactly. All the students are telling the correct answer. Okay. This is premature separation of placenta. Premature separation of placenta, so that between the placenta and the decidua, there is a clot formation or there is a blood clot formation. This is known as abruptio placentae. One of the important risk factor for this is hypertensive disorder during pregnancy or preeclampsia. So never forget this. This is an important point. Now let's move on. Another is poor fetal growth caused by a lack of nutrients and oxygen. Poor fetal growth caused by a lack of nutrients and oxygen. Now, why is this? We should understand there is vasospasm going on in most part of the body, especially in that utero-placental circulation, definitely. So as a result of vasospasm, there is decreased delivery of the nutrients and oxygen towards the baby. So over a period of time, the baby will suffer from malnutrition. This is known as intrauterine growth retardation, IUGR. So the baby looks quite small at the time of birth. But remember, this is not equivalent to preterm baby. Okay, usually the baby has already attains the maturity, but the baby looks smaller than the normal as a result of growth retardation. Preterm birth can happen. Low birth weight baby is a result. The definition of low birth weight, anyone can tell me what is the meaning of low birth weight? What is the definition?
sir baby less than made of 3
Less
kg.
than 5 pounds.
In
Maybe
kg?
less than 2 kg.
Now there are different. Now there are
Sir,
different. Yes, yes.
So 2.5.
maybe less than
Maybe
3.5
less than
kilogram.
5 pounds.
Sir, maybe less than 2.5 kg, sir. I believe.
Okay, okay. Now see that there are so many different answers coming, but please, this is a standard definition. You cannot give your own answer here. So according to the World Health Organization, low birth weight baby means less than less than 2.5 kg. This is the one, less than 2.5 kg or 2500 gram, whatever way you want to answer. That is low birth weight baby. Don't forget that. It's a very important one. I'll take a big class about this in pediatrics in the next semester for you. Now, stillbirth means dead baby, okay, because it can cause a serious problem and the baby may be born dead. Damage to kidney, liver, brain, and other organ and blood system, definitely. That's why the multiple organ dysfunction can occur. A higher risk of heart disease because of hypertension, there may be damage to the heart. Eclampsia may result, okay, and eclampsia is a disorder or dysfunction of the brain, which can cause seizure or even coma. And HELLP syndrome can occur when the liver is damaged, when there is hemolysis, and when there is low platelet. This is the full form of HELLP syndrome. H stands for hemolysis or hemolytic anemia. EL, elevated liver enzyme, and LP is low platelet. Okay, so these are some of the important complication or problem, you can say. Now with this discussion, let's move on to the severe preeclampsia. What is the difference between mild preeclampsia and severe one? After this slide, you can exactly tell me what is the difference. Okay, so please pay attention here. The diagnosis is made on the basis of the finding of mild preeclampsia plus any one of the following feature, that is sustained blood pressure elevation of greater than or equal to 160 systolic over 110 diastolic, equal to or more than that. Okay, 160 systolic and 110 diastolic, very easy to remember. Second is proteinuria. Now this proteinuria is a bit of massive one. On dipstick analysis, it should be 3 plus to 4 plus, or on a 24-hour urine collection sample, it should be equal to or more than 5 gram. This is a heavy proteinuria. Another evidence of maternal jeopardy means there is some problem in the mother already because of this preeclampsia, like headache, epigastric pain, and visual changes. Now, headache and visual changes are because of raised ICP, raised intracranial pressure because of hypertension. Okay, or that hypertension may have caused papilledema, and that papilledema has caused visual changes, also known as blurring of the vision. Epigastric pain, okay, is because of congestion of the liver. Congestion of the liver. It's one part of the HELLP syndrome actually. Thrombocytopenia occurs, we already talked about, and according to the definition, it is less than 100,000 per microliter. This is microliter, okay? Or you can say less than 1 lakh per microliter. There is elevated liver enzyme, SGOT and SGPT are raised than the normal. Pulmonary edema, fluid collection inside the alveoli. Oliguria, decreased urine formation, that is less than 750 ml per 24 hour. Okay, different books mention this definition differently, but do not worry about that. It is lesser urine formation than the normal. IUGR in the baby or even cyanotic baby. So these are the different problem in the mother as well as baby, especially in the mother. And edema may or may not be seen. Usually edema occurs, usually. Okay, so these are some of the important points. Now the question comes, what is the difference between severe preeclampsia and mild preeclampsia? Just remember some complication, some other features which was not present in preeclampsia, and your answer would be completed. And those are headache, epigastric pain, visual changes, low platelet count, different features of HELLP syndrome, pulmonary edema, oliguria, okay, and blood pressure rise is definitely higher because we are talking about severe type of preeclampsia, and that is equal to or more than 160 systolic over 110 diastolic, and proteinuria is also massive. Let's move on. Now, what are the risk factors of severe preeclampsia? See there. These are the same as mild preeclampsia with the addition of disease with a small vessel disease such as systemic lupus and long-standing over diabetes. Now, the same risk factor which we have discussed in mild preeclampsia works for severe preeclampsia as well. Primipara and so many different, for example, previous history of preeclampsia in the family, right? Obesity, isn't it? Even diabetes, there are so many others. So apart from them, if this lady is also having some connective tissue disorder like systemic lupus erythematosus or other connective tissue disorder per se, and if she is having long-term diabetes, over diabetes means long-term diabetes or chronic diabetes, there may be complications of diabetes already, and one of the complication is vascular complication, then there is a higher chance of development of severe preeclampsia. Regarding the etiology and pathophysiology, it is again similar to the mild preeclampsia. There is diffuse vasospasm in most part of the body, okay, especially in the uteroplacental circulation, and that can result in multi-organ dysfunction. Now, one important point I like to highlight here, though we are talking this as a part of pregnancy complication, but remember, in most other organs in the body, okay, there is decreased blood flow occurring in this disorder. So the exact mechanism how this occurs is still not known. It's just the speculation. It's just the hypothesis. And one very, very interesting fact is after the delivery, okay, most of this lady, not 100%, okay, majority or most of the lady will come back to the pre-pregnancy state. So they don't have anything left behind. But some unfortunate lady will still have a rise in blood pressure even after the delivery. Now the presenting symptoms, okay, already talked about in the diagnostic point. So this is a bit of repetition for you. Presence of new onset of persistent headache, epigastric pain, or visual disturbances is characteristics of severe preeclampsia. These are the severe symptoms. If they are present, definitely it is a severe case. And regarding the lab abnormality, we can go for CBC. CBC may show hemoconcentration because of edema. Hemoconcentration is quite common because of most of the fluid will leaking outside, resulting in excessive hematocrit. That is called hemoconcentration. Proteinuria is already talked about. There may be evidence of disseminated intravascular coagulation and hepatocellular injury. Now, how I find hepatocellular injury in my investigation? How I know that? Anyone?
Sir, we'll have elevated liver enzyme.
Elevated liver enzyme.
enzymes.
Elevated liver enzyme, SGOT and SGPT.
Very good answer. Excellent. This is liver function test you order, and one part of the liver function test is elevated liver enzyme, AST or ALT or SGOT or SGPT. Definitely. At the same time, you'll also order what is the total serum bilirubin, what is the direct component, what is the serum albumin level, and what is prothrombin time. But in this context, the important one are elevated liver enzyme. Now, let's talk about the management. This is a case of severe preeclampsia. Aggressive prompt delivery is indicated. See this. Aggressive prompt delivery is indicated for severe preeclampsia at any gestational age with evidence of maternal jeopardy or fetal jeopardy. Now, there is a big difference between the management of mild type of preeclampsia and severe preeclampsia. Remember what we talked just now? In mild preeclampsia, if the baby is very premature, okay, we go for conservative management. We try to prolong the period of pregnancy. But here, we do not care about the gestational age. If there is some problem to the mother already because of this disorder, or fetus is already harmed by this, then aggressive prompt delivery is indicated. Now, how to do that? Let's talk about it. Okay. Now, delivery can be done by either vaginal route or by cesarean section. Vaginal route or by cesarean section. Now, by vaginal route, you need to induce it, isn't it? You need to induce it. Now, the induction of labor topic was already done. So, what are those agents to induce the labor? Can you answer me? How we induce the labor? Exactly.
Prostaglandins.
Very good. So first is oxytocin, another is prostaglandins, third is artificial rupture of membrane, or another something known as balloon dilatation. Excellent. So these are the way to induce the labor. Okay, we can go for this. Or cesarean section is already there. Now administer intravenous magnesium sulfate to prevent convulsion. This is a special drug here. Magnesium sulfate, IV, to prevent the convulsion. That means she will not go to eclampsia. It is given as 5-gram loading dose, then continue the maintenance dose of 2 grams per hour. This is how we give it. The dose is not really necessary to remember at this time. Lower the blood pressure to diastolic values between 90 to 100 with intravenous hydralazine and labetalol. Now look at this drug here. Hydralazine is a type of vasodilator. And what is labetalol? What type of drug is this?
Beta 1 blocker.
Exactly.
Cardioselective beta blocker.
Exactly. Okay. It's a type of beta blocker. We all know that, and it is a also considered as a type of vasodilator substance. These are a powerful type of medicine, hydralazine and labetalol, and they are they do not harm the mother or the baby at that time. That's why we are choosing for this. There are so many other medicines, but all of them cannot be used during pregnancy. Another one is called methyl dopa, but methyl dopa can be used in a bit of earlier situation than the later. Okay, please mute yourself. Now, attempt the vaginal delivery with IV oxytocin infusion, okay, if mother and fetus are stable, that we already talked about. Now, one small question for you. This diastolic blood pressure, just have a look here. It is still more than 90, still more than 90, right? And if it is still more than 90, it is still in the hypertensive range. Why don't we try to bring that blood pressure way down towards 80 or 70? Yes, why we never do that? Anyone?
Sir, because there is also vasospasm. If that's why we don't want to decrease the blood pressure, because if we decrease the blood pressure, there is no perfusion to baby in placenta through.
Sir,
Yeah, please go
sir,
on. Very good. Yes, you can continue, Uzair. Yeah, I'm listening. Anybody can answer. Yes.
Sir, because many of the arteries, like sir, during the pregnancy stage, sir, they have that mild vasoconstriction, sir. And if we reduce that pressure more, so sir, that the perfusion to many of the vital organs and to the fetus will be decreasing, sir. So that's why we cannot decrease it to that normal range of 80, sir.
Exactly. Both answers are absolutely correct, and they are answering the same thing. So remember this all the time, okay? Even this principle works for other hypertensive patient as well. Even in a hypertensive stroke, or a hemorrhagic stroke, this principle is applicable. We do not decrease blood pressure so much that the perfusion pressure in those different organs will be decreased. We never do that, because already the vasospasm is occurring, and we still need a little bit more pressure to push the blood there. Okay, so this is the important point. So don't try to bring blood pressure suddenly to the normal.
Excuse me, sir.
Yes.
Sir, what about systolic pressure? If we only concentrate on diastolic pressure.
No, systolic pressure is also kept a little bit higher. Okay, it is also kept a bit higher, probably in the range of around 140, around 140, 120 to 140 range.
Okay, sir.
Now let's move on. Severe preeclampsia. Now, what are the other types of management here? There is a role of conservative inpatient management, but there are certain criteria we should fulfill. Okay, this is a serious condition, so until and unless those criteria are fulfilled, you don't go for conservative management. Now, let's talk about it. It may rarely be attempted in the absence of maternal and fetal jeopardy, means the health of the mother and the fetal complication should not be there. Okay, and gestational age should be between 26 to 34 weeks. If blood pressure can be brought below 160 over 110. So these are the important criteria. This should take place in an intensive care unit or tertiary care setting in a good hospital. This is ICU care. So a bit of complicated situation, isn't it? That's why you usually do not go for conservative inpatient management. You directly go for the termination of pregnancy by inducing the delivery, and then after that everything would be coming back to the normal. Continuous IV magnesium sulfate should be administered to the mother, and maternal betamethasone should be given to enhance the fetal lung maturity, especially if the baby is in premature stage. We already know the purpose of this. This betamethasone is a corticosteroid. It is given so that the surfactant will be formed in time, and surfactant is necessary to decrease the surface tension inside the alveoli. Okay, so let me clarify a little bit here. If surfactant is not there, those alveoli will remain collapsed. They don't open up. And without them opening up, there is no gas exchange. So after the birth of the baby, okay, it can result in respiratory distress syndrome, also known as hyaline membrane disease. That's why betamethasone and dexamethasone are important drug in case of premature baby, but they should be given before the delivery. Regarding the complication, progression from severe preeclampsia to eclampsia may occur. We already talked about this. Let's move on. Now, all of you, please focus on this slide. Okay, so this slide is a bit of informative one for you. So let's take a bit of time here. See that, please. Now, this one is a rising high blood pressure above the normal. We already know that. Without high blood pressure, the hypertensive disorder of pregnancy is not talked at all. There is weight gain because of edema. There is proteinuria. There is blurred vision, headache, and irritability. There is swelling of the leg or swelling of the face. See there? This is a feature of edema. There is abdominal pain. This is because of liver congestion. There is a seizure and coma. This is a feature of eclampsia. So all these things, every student are quite familiar now. And these are the complications. See there, eclampsia is a complication. Cerebrovascular accident is a complication. And you all know what is the meaning. There is a rupture of a blood vessel inside the brain. Because of very high blood pressure, that complication can occur in the lady. There may be renal failure because of high blood pressure. Once again, there is intrauterine growth retardation in the baby. There is placental abruption or abruptio placentae, which is a premature separation. There is increased mortality and morbidity of the baby. There may be development of disseminated intravascular coagulation. It is, it can be directly produced by very high blood pressure because of different complication, or it may be associated with abruptio placentae as well. There may be HELLP syndrome, hemolysis, elevated liver enzyme, and low platelet. There may be pulmonary edema, okay, and there may be liver complication, means liver dysfunction may be there. It's a part of HELLP syndrome. We already talked about. So, though it is a placental disease, okay, it may start from the placenta, but later on, most of the organs of the body are affected. Now, with this, let's move on to the discussion of eclampsia. Now, look at the definition here. The presence of unexplained grand mal seizure in a hypertensive proteinuric pregnant woman in the last half of pregnancy, that is beyond 20 weeks of gestation. Okay, beyond 20 weeks of gestation. If she develops hypertension, if she develops proteinuria, and suddenly if she develops grand mal seizure, then this condition is known as eclampsia. Now, what is grand mal seizure? Once again, what is it?
The tonic-clonic seizure, sir.
Exactly. Exactly. It is generalized tonic-clonic seizure, GTCS, generalized tonic-clonic seizure. Now, a bit of explanation here. Generalized means all over the body. Tonic, okay. Tonic means spasm of the muscle. Remember this. The whole body is under spasm. The muscles are contracting during that time. And clonic means rhythmic extension and flexion movement, rhythmic type of movement. This is called clonic. So everything together, okay, is called grand mal seizure. Risk factors same as mild and severe preeclampsia. So we don't discuss about them again. But one important point, a primary seizure disorder does not predispose to eclampsia, and that should be ruled out. So take a good history, okay? Family history, personal history, past history, everything should be taken. Is this lady epileptic patient or not in the past? So that should be asked. Regarding the etiology and pathophysiology, pathophysiology is severe diffuse cerebral vasospasm resulting in cerebral perfusion, which deficit means it decreases or cut off the blood supply in certain areas of the brain. That area may develop ischemia, and then eclampsia may result. At the same time, there is diffuse cerebral edema. So this is one of the target organ damage. Presenting symptom is a tonic-clonic seizure on the setting of mild to severe preeclampsia. Regarding the lab abnormality, it is same, okay, as mild or severe preeclampsia. That means proteinuria is a very important feature. You have to go for liver enzyme analysis just to make sure this is a case of HELLP syndrome. Go for the confirmation of DIC and things like that. Okay, diagnosis we already talked about. Now the important part, what is the management? The first step is to protect the mother's airway and the tongue. Now why is that? Yes, why is this important?
Sir, because due to aspiration and hypostatic infection and edema there is a laryngeal edema maybe, and mainly sir due to pneumonia due to aspiration, because in tonic-clonic seizure.
Good. So many important points you have mentioned. Now see there.
Sir, due to seizures, she can bite her tongue also.
Good.
To basically
Protect
the any opportunistic infection that from the airways or the tongue.
Good. Now see there. Okay, listen properly here. This is a case of generalized tonic-clonic seizure. After GTCS or grand mal seizure occur, that patient would be unconscious. She cannot maintain her posture and she become unconscious for certain duration. Now, when somebody is in coma or develop unconsciousness, that person cannot protect the airway. The gag reflex is lost during the time, so there is a very high chance of aspiration pneumonia. Always remember this. This is not only in the case of eclampsia, this is in any coma case. And in this condition, why unconsciousness or coma? Because of grand mal seizure. Okay, after grand mal seizure, the loss of consciousness is quite common. That's why we should protect the mother's airway and the tongue. Now another question, how to do that? The best way to do this is endotracheal intubation. Okay, put endotracheal intubation in the mother with a cuffed endotracheal tube. That will help. Another one, simple positioning of the head. And we always put the lady in the left lateral position, not in the supine position, because whatever a vomitus is present in the oral cavity, it will trickle from the corner of the mouth if she is in lateral position. Okay, always remember this. Then check whether the tongue is fallen back or not. Sometimes the tongue may fall back and the tongue itself is blocking the airway. So if that is the case, what can we do? We can put an oral tube. There is something known as oropharyngeal or oral tube. That oral tube will compress the tongue and even open the airway. So these are the different things. Administer magnesium sulfate. This is a drug of choice here. Magnesium sulfate with an intravenous bolus of 5 gram to stop the seizure and continue the maintenance infusion rate of 2 grams per hour. So if somebody asks you which is the drug of choice in case of eclampsia, remember the name magnesium sulfate. Another is aggressive prompt delivery is indicated for eclampsia at any gestational age after stabilization of the mother and the fetus. I don't care if the lady is in 20 weeks of gestation, 24, 28, 32, or 40 weeks. My management is aggressive prompt delivery. I don't go for conservative management. I'll deliver the baby after stabilizing the mother and the fetus. I'll try to save the life of mother and the fetus both. That is the goal of our management, isn't it? So attempt vaginal delivery with intravenous oxytocin infusion if mother and fetus are stable, and lower the diastolic blood pressure between 90 and 100 with intravenous hydrazine and labetalol. It's the same like a severe preeclampsia management. It's the same thing. And regarding the complication, intracerebral hemorrhage can lead to death in the mother. So if the blood pressure is very high, we need to decrease it up to a certain level. We don't keep it so high so that there is a chance of rupture of the blood vessel, which can lead to hemorrhagic stroke, and because of a lot of complication inside the cranial cavity, she may die. So these are the complications. Okay. So after talking about eclampsia, let's talk about another type of hypertension which may occur during pregnancy, that is chronic hypertension. Chronic hypertension means it is already there prior to 20 weeks of gestation or even prior to the pregnancy. The risk factors, regarding the risk factors of chronic hypertension, you have already studied the topic of hypertension probably in medicine. Most of them are idiopathic or essential hypertension. We do not know the cause. The same thing occurs here as well. And regarding the risk factors of hypertension, okay, some other types of hypertension are known as secondary hypertension also. So not always it is a primary. In a discussion of medicine, we say 95% of the hypertensive cases are essential or primary, and around 5% are a secondary. So similar type of a concept works here as well. So the risk factors are obesity, advanced maternal age, that means after 35 years, positive family history, renal disease, okay, has a high chance of hypertension development, especially chronic renal failure, diabetes, and SLE and other types of connective tissue disorder. So there is a higher chance of development of chronic hypertension. These are the risk factors. Let's move on. Regarding the etiology and pathophysiology, the pathophysiology is similar. There is a vasospasm, okay, diffuse type of vasospasm in different type of circulation, which causing decrease end organ perfusion. So that decrease in organ perfusion is causing the problem here. Regarding the diagnosis, okay, you need to make sure she is hypertensive and just take the blood pressure. If it is more than or equal to 140 systolic over 90 diastolic, okay, and that should occur prior to 20 weeks of gestation, then your diagnosis is fulfilled. Now, a bit of important part, these are, everybody know, that's why I was going a little bit faster, but please pay attention now. The pregnancy prognosis with chronic hypertension, how is it? What is the chance of, pregnancy outcome? Is it good or bad? Now, good, prognosis is in this situation. It is favorable, okay? Maternal and neonatal outcome is found in patient with blood pressure values between 140/90 and 179/109, and no evidence of end organ damage. So very easy to understand. The blood pressure is also not that severely high, and during the history taking or physical examination of investigation, we have not found any evidence of end organ damage. Now remember the end organ for hypertension. Can you name those end organ once again? What are the end organ or target organ for hypertension?
Cardiac, renal, or any retinal.
Very good. One is brain, another is heart, another is kidney, and the fourth one is eye. Okay, or heart, you can also say cardiovascular system, that is even better. heart as well as blood vessels. So brain, okay, cardiovascular system, kidney, and the eye. These are called target organ for hypertension. They are also known as end organ damage. That's what we are talking right now. Poor pregnancy outcome would occur in this situation. Now, pregnancy complications are more common in patients with severe hypertension with the following end organ damage like cardiac, renal, and retinal. Retinal means eye complication. So what are these? Let's talk about that. Pregnancy loss rate increased significantly if serum creatinine value are greater than 1.4 milligram per deciliter. Now, you all know, okay, blood urea nitrogen and serum creatinine are the part of renal function test. If kidneys are damaged, then serum creatinine and blood urea nitrogen are higher than the normal. So see there, this is already in the upper range, okay, 0.8 to 1.4 or 0.6 to 1.4. It depends on the different textbook. Actually, that's the range of creatinine. If it is more than that, it is high. So renal disease has already occurred because of blood pressure elevation. So it will carry the poor prognosis. That is the meaning. Let's move on. Another is retinopathy. Long-standing hypertension is associated with retinal damage, including hemorrhage, exudate, and narrowing of the vision. Okay, narrowing of the vision. We'll talk about that. Now, see here, retina is the most inner layer of the eyeball. Our eyeball has got three coat or three layer. The outermost layer is called sclera along with cornea. The middle one is called uvea or uveal tract, and the innermost is called retina. Now, because of the long-standing or prolonged hypertension or chronic hypertension, there is retinopathy. That means there is hemorrhage, there is exudate. Exudate means leaking of the protein-rich fluid outside, and there is narrowing of the blood vessel. Okay, means they are, undergoing into spasm, and because of the all these probably complication, the vision itself is narrowed. Now, what about in the heart? There is left ventricular hypertrophy in the heart. You all know, you are studying this from the pathology lecture. Because of prolonged hypertension, the left ventricle is hypertrophied. Okay, this is known as pressure hypertrophy of the left ventricle, and this is seen mostly in women with prolonged blood pressure values of more than or equal to 110 over 100 and 180 over 110. 180 means systolic, 110 is diastolic. Okay, so this is the point. Now, the worst prognosis is seen if the and that is more than 10 times higher chance of fetal loss if uncontrolled hypertension is there before conception or in the early part of the pregnancy, and if it is associated with superimposed preeclampsia. What do you mean by that? The lady is already having chronic hypertension. On top of that, preeclampsia has occurred after 20 weeks of gestation. Now, this is considered a very serious issue, and the the chance of fetal loss is 10 times more than in the general population. Now, whatever you have discussed in this chronic hypertension, everything is revised once again in this slide. So please pay attention here. This is a chronic hypertension which has got poor prognosis. Okay, now see there. So let's focus on the poor prognosis here. Kidneys, if they are damaged already, if there is retinopathy already, and if the heart is already damaged because of prolonged hypertension, then poor prognosis on the outcome of the pregnancy. Whereas if the blood pressure is still in this range, it is high, but it is not that very high, and if there are no end organ damage, then the outcome of the pregnancy is still good. Worst prognosis occurs in uncontrolled hypertension, okay, with superimposed pregnancy-induced hypertension or preeclampsia. That is the worst prognosis. That the chance of fetal loss is 10 times more. Now, can you tell me what test this doctor is doing on that lady? Which test is this?
Accommodation test.
Now, so this is a bit of a difficult question for you actually, because we have not discussed like this before. This is known as ophthalmoscope. This special instrument is called ophthalmoscope. It is used to look the fundus of the eye. Fundus means retina. So we'll focus on the pupil and we look inside the eyeball. That means in the retina. We look for the optic disc and we look for the surrounding retina. Okay, so this is a skill every doctor should develop. And don't worry, you will definitely learn it during your internship when you start working in the hospital. When a lot of patients are there in front of you, you should buy this ophthalmoscope and then start looking the fundus. Now see here, this is how the normal fundus look like. So let me give you a bit of information here because this is very important concept. This is called optic disc. Optic disc means head of the optic nerve. This is the area from where optic nerve starts. Okay. Now these are the branches of central retinal artery and tributaries of central retinal vein. Central retinal artery branches from here, and central retinal vein, all the vein will collect here and then drain back as a central retinal vein. These are the different branches. This is optic disc, and at the center you can see this area. This is called optic cup, and this is optic disc. In the normal person, we can see the whole circumference of this disc very clearly. Okay, see this. This is quite clear. This is not blurry. I can see this everywhere, and I can see. I can trace these blood vessels also. I cannot see they are abnormal here. So this is normal fundus. This is called macula. Macula is the area from where we see the brightest or sharpest of the vision. Okay, we call it acute vision. Means sharpest of the vision is possible because of macula. This is also known as fovea centralis. This inferior arcade is the branch of the blood vessel which is going inferiorly. Now all of you please focus here. Once again, the different things are labeled here. This is the optic disc. Optic disc. Here is the retinal artery. Okay, this is retinal vein. This is superior temporal quadrant, superior nasal quadrant, inferior nasal quadrant, and inferior temporal quadrant. Now, what is the meaning here? This retina or fundus is roughly divided into two parts first, that is temporal side and the nasal side. This is temporal side. This is nasal side. So again, the temporal is superior and inferior. So this is how it is divided into different quadrant. This is macula once again. Now, this is a normal retina and this is a disease retina. Okay, now see this. This is the optic cup. Here is the optic disc. This is macula, and these are the blood vessels. This is a normal retina. This is a abnormal one. Why it is abnormal? There are different things. There are hemorrhage, dot-like appearance. This is neovascularization, new blood vessel formation. There is microaneurysm, and there are hard and soft exudate. So because of this, okay, it is abnormal type of retina. And this is seen in diabetic retinopathy. Diabetic retinopathy very commonly affects retina like this. Now, this is not a case of diabetes, okay? This is a case of hypertension during pregnancy. But why this slide is included here? Just to make sure that how abnormal retina looks like in comparison to the normal. Now see there. So this is the a bit of magnified view once again. So if you see these different types of hemorrhage occur in hypertensive retinopathy as well. But microaneurysms are the hallmarks of diabetic retinopathy. These hard and soft exudate can occur, and these are venules and arterioles. Here is the optic disc, okay, and the central part is called optic cup. Now, one small point I like to highlight here: when you look at the fundus like this, and if this margin is not clear, there is a blurring of the margin of the optic disc. It looks like edematous from the surface. What we call that situation? What we call that condition?
Edema.
Papilledema.
Papilledema.
Exactly, papilledema.
Papilledema.
This is known as papilledema. Very good, papilledema. Okay, so that's the concept I want to provide to you. Papilledema is seen in case of long-standing hypertension sometimes. Now, another important part of today's lecture is a chronic hypertension with superimposed preeclampsia. Let's talk about it. Now, the meaning is important first. What is the meaning here? The lady is already having chronic hypertension. On top of that, after 20 weeks of gestation, she develops feature of preeclampsia. So this is like a double hit, okay, double hit on that lady. So because of this double hit, there is a chance of a lot of complication. Okay, I'm making it very easy for you. Now, this complication occurs in 25% of the patient with chronic hypertension, and the risk factors for the development of this include renal failure or renal insufficiency, hypertension for previous 4+ years, and hypertension in a previous pregnancy. 4+ means, nearer the duration. It is not, very, long time ago. It's not like that, like 10 or 15 years ago, not like that. Okay, within the 4 years or a bit before that. Adverse pregnancy outcome for both mother and baby are markedly increased. We already discussed about the prognosis here. In case of superimposed preeclampsia on chronic hypertension, there is 10 times more chance of fetal loss. So that tells everything for us. Regarding the lab abnormality, see there, it is not very much different. The chronic hypertension patient have a spectrum of etiology and disease severity, already talked about. And those with mild hypertension and no end organ involvement have normal lab test. Definitely, if the end organs are not damaged, then why the lab test would be abnormal? If you take the chest X-ray, the heart size looks normal. Okay, if you do a liver function test, the liver functions are fine because the organs are not damaged. Whereas those with renal disease may have evidence of decreased renal function, like increased blood urea nitrogen and serum creatinine, and there may be proteinuria also. Okay, there is lowered creatinine clearance, means decreased GFR. There is elevation of blood urea nitrogen, already talked about, increased creatinine in the blood, and there may be increased uric acid also because it is not excreted by the damaged kidney. So in one sentence, what I like to highlight here is, if you do different, investigation targeting the different end organ function, they may be abnormal. Let's move on. Now, which are the antihypertensive drug we use to treat this situation, and what are the different issues regarding this? Now see here. Discontinue the medication in patient with mild to moderate hypertension caused by the normal decrease in blood pressure that occurs in pregnancy. Now, what do you mean by that? During pregnancy, we have studied that long time ago, if you remember, during the physiological changes during pregnancy, the blood pressure slightly drops, okay, in case of pregnancy. So if the lady is already having mild to moderate hypertension prior to, she become pregnant, or prior to 20 weeks of gestation, that's what chronic hypertension is all about. Because of the natural decrease in blood pressure during pregnancy, it will balance the things up there, So you don't need to use medicines actively. That is the meaning. Pharmacological treatment in patients with diastolic blood pressure less than 100 doesn't improve either the maternal or fetal outcome. So you don't need to treat during this situation. Whereas you need to use medication in these conditions. Let's talk about them now. This may be necessary in patients with severe hypertension. Okay, severe hypertension definitely necessary. That is systolic blood pressure more than 160 to 180 and diastolic blood pressure more than 110. We definitely need to use the medicine. The drug of choice is methyl dopa because of extensive experience and documented fetal safety. So methyl dopa is an important antihypertensive drug we use during pregnancy. Whereas labetalol and atenolol are acceptable alternative, but beta blocking agents are associated with intrauterine growth restriction or retardation. So we do not use it for a longer duration during pregnancy. Methyl dopa is much safer than them. But having said that, if the blood pressure is very high and if you want to decrease it, labetalol can be tried. Now, what are the other parts of the management? Conservative outpatient management, okay, can be done in uncomplicated mild to moderate chronic hypertension. Okay, simple blood pressure is high, no target organs are damaged, we can go for conservative OPD management. Drug therapy is stopped, okay, in those situations which I just talked about. No target organ damage, and if the blood pressure is mildly high or even moderately high because of the effect of the pregnancy, it may balance things up there. So you can stop the drug therapy also, but close monitoring is necessary. Serial ultrasonography, sonogram means ultrasonography, and antenatal testing is appropriate after 30 weeks of gestation to monitor for increased risk of IUGR. That is one of the significant complications of hypertensive disorder in pregnancy, that is IUGR. So we need to monitor for it. Serial blood pressure and urine protein assessment is indicated for early identification of superimposed preeclampsia. How we diagnose preeclampsia? Proteinuria is one of the very important component. The lady is already hypertensive, remember this. On top of that, if she starts to pass proteinuria, if she develops more edema than before, then we know she is having superimposed preeclampsia. Now, this is a serious condition. Now, what we do during that time? We induce the labor at term if the cervix is favorable. Now, what do you mean by favorable cervix? Who can answer this? Yes?
So basically, the dilation of the dilation of cervix. That's the most important point, sir. In a favorable cervix, and sir, the cervical effacement as well, sir, and the stretching of cervix mainly, sir.
Sir,
Good.
cervix
Yes,
dilated,
please.
efface, soft, and anterior mid position.
Good, very good point. Very good. So many other students also know this. You can just answer like this. We do whether the cervix is favorable or not, or we decide by doing Bishop scoring. That's it. Okay. If you answer like that, your teacher will understand. If you are not confident about Bishop scoring, you don't spell the term. So many of the teacher will not even enter into the Bishop score. But if they ask, please be prepared about the Bishop score answer. That's it. Cervix, whether it is favorable or not, will decide by doing Bishop scoring. And induction of the labor at term is done if the cervix is favorable. Aggressive prompt delivery is indicated for chronic hypertension with superimposed preeclampsia at any gestational age because of the single reason the fetal loss chance is 10 times higher than other pregnancy. And during that time, we can use magnesium sulfate to prevent the convulsion and keep diastolic blood pressure between 90 to 110 with intravenous hydrazine labetalol. See this? The management is still the same. because it is also a type of hypertensive disorder in pregnancy. Attempt a vaginal delivery with intravenous oxytocin if the mother and fetus are stable. Now, please, all of you, focus on this slide. What is written here? Hypertensive medication never to use during pregnancy or with pregnancy are ACE inhibitor and diuretic, especially the ACE inhibitor. ACE inhibitors are strictly contraindicated during pregnancy. They can induce fetal renal failure. Okay, and diuretics like furosemide, hydrochlorothiazide, and these type of diuretics, they decrease the plasma volume. That's how they act. They decrease the plasma volume, and by decreasing the plasma volume, they can decrease the blood flow towards the baby. So these are not used during pregnancy. Now see here how to manage chronic hypertension with superimposed PIS. This slide is a summary of the thing which we have talked. Use magnesium. Yes.
Sir, if there is pulmonary edema in a severe hypertension, then what will we use for pulmonary edema?
That is an excellent question you have asked. Okay, very good. Now during that situation, we need to use furosemide, because saving the life of the mother is more important than saving the life of the baby. Now this is a very difficult decision. Okay, very, very difficult decision. But always remember one thing: you save the tree rather than saving the fruit. This is a very common statement used by the obstetrician or even by the doctor. Saving the life of the mother is always important than saving the life of the baby. Having said that, all pulmonary edema is not going to kill the lady, isn't it? But 1 or 2 doses of furosemide may rapidly improve the status of pulmonary edema, and it may not that harm the baby also. The point is, do not use that consistently for the treatment of hypertension. Hypertension treatment, you need to take medicine every day, isn't it? Just not 1 or 2 doses. So that's the point we are talking here. But if she is having pulmonary edema, I'll definitely go for furosemide treatment in the mother. And if it does harm to the baby, okay, we can manage that, because we don't use furosemide for a long time in the management of pulmonary edema. Let's move on.
Okay, sir.
Now see this. See this. IV magnesium sulfate is given to prevent convulsion. There's no doubt about it. This is the drug of choice in case of eclampsia, even for the treatment and preventing purpose. Lower the blood pressure by using hydrazine or labetalol, and the range of blood pressure is 90 to 100 millimeter of mercury diastolic. We do not consider the systolic here, but at the same time, systolic is also decreased than that range, but it is still not in the normal value. And induction of the liver is done by IV oxytocin or amniotomy, means artificial rupture of the membrane, if both mother and fetus are stable. Now, look at this slide. This is again a type of revision for you, okay? And this is we call as a bit of algorithm. See this? So sustained increase in blood pressure more than 140 over 90 without proteinuria is called gestational hypertension. See this? This is what we talked. So if somebody asks you what is gestational hypertension, just confidently answer like this. And usually it occurs after 20 weeks of gestation. Now, chronic hypertension, okay, hypertension before 20 weeks or even pre-pregnancy or prior to the pregnancy. Now, every students are confident about this. Chronic hypertension, okay, with superimposed preeclampsia is this one. Increase in blood pressure and proteinuria with chronic hypertension. Now, eclampsia with unexplained seizure. Along with all these, plus means everything is happening with additional feature. Severe, mother or fetus jeopardy is there, means some complications have already occurring in the mother and baby. And mild PIH is pregnancy-induced hypertension, is the short form. there is no jeopardy of mother or fetus. How to manage it? These are the conservative management, and these are the inpatient management. This is outpatient, OP is outpatient, IP is inpatient management. Magnesium sulfate, antihypertensive drug, and delivery of the baby. These are the three things. If somebody asks you why magnesium sulfate is used, two answers. One, to prevent from the convulsion to occur, or if the convulsions are already occurring, then also I can use magnesium sulfate to control it. If the gestational period is less than 36 weeks, okay, inpatient conservative management can be done, but make sure the mother and fetus, conditions are stable. If more than 36 weeks, you don't need to wait, deliver the baby. Now, what is HELLP syndrome? Okay, we have coming towards the end of this very, very important topic. This is a combination of hemolysis, elevated liver enzymes, and low platelet count. Absolutely common question in the Viva exam. Okay, HELLP syndrome. Now, let's talk a little bit about this. This occurs in 5 to 10% of pre-eclamptic patient and is characterized by hemolytic anemia, elevated liver enzyme, and low platelet. And which are those liver enzyme? Okay, that is the common question your teacher love to ask. So every student know this by now, but still let me write that for you. ALT and AST. ALT and AST. Alanine transaminase, aspartate transaminase. Alanine transaminase is also known as SCPT. Aspartate transaminase is also known as SGOT. Regarding the risk factor, this occurs twice as often in multigravida as primigravida. And differential diagnosis can be other conditions like thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. Like, can you keep this under one umbrella? You have recently talked this in a topic of anemia. We have done the classification
Microangiopathic hemolytic anemia.
Excellent.
Microangiopathic hemolytic anemia.
Very good. I got your answer. Excellent. That's what I want you to answer here. Remember, this HELLP syndrome is a similar type of situation under microangiopathic hemolytic anemia. TTP, HUS are other conditions which looks quite similar. If I talked in detail about this, the different organ dysfunction, hemolysis, and those type of things matches along with them. That's why they are considered as a differential diagnosis. Let's move on. Now,
Sir,
yes.
Sir, regarding the liver enzymes, sir, we've also got some other important liver enzymes, like, sir, like the GGT, the glutamyl transpeptidase, and sir, the AST, sir. So, sir, will they also be increased, or sir, only these two are the specific one that will be increased in the HELLP syndrome?
Very good question you have asked. Now remember, there are so many other types of liver enzyme. Absolutely correct. Okay, like gamma glutamyl transpeptidase, 5-nucleotidase, and alkaline phosphatase. Now, the important point you need to remember here are ALT and AST are called parenchymal liver enzyme, and those three which we have listed are called biliary canalicular liver enzyme. So in case of parenchymal damage of the liver, AST and ALT are excessively released, or they are increased in a higher amount. ALP may be high because of the compression of those small biliary canaliculi. Sometimes ALP or alkaline phosphatase may be high along with them, but the range of increase is never same as ALT and AST. Whereas GGT and 5-nucleotides are strongly connected with biliary duct. So in case of obstructive jaundice, or when they are blocked, then only those enzymes are elevated. That's why we have not taken their name, because of this reason.
Okay, thank you, sir.
Okay, fine. So let's talk about how to manage the case. prompt delivery at any gestational age is appropriate because this is a serious condition. We don't do conservative management in this type of situation. So prompt delivery at any gestational age is important. And if your teacher asks how to do prompt delivery, you just say induction of the labor. That's it. Regarding the cesarean section and vaginal delivery is considered safer here, okay, rather than cesarean section. But if if you want to save the life of the baby, for example, some fetal distress you have picked during the examination, along with all these features, you can also go for cesarean section. It is not absolutely contraindicated. Use of maternal corticosteroid may enhance postpartum recovery, just to make sure the fetal lungs are mature. Regarding the complication of HELLP syndrome, DIC is one of the complications. Abruptio placentae, fetal demise or death of the fetus, ascites, and rupture of the liver. All these are associated, complications of HELLP syndrome because of pregnancy-induced hypertension. Now, at the end, okay, let's do some clinical problem. And if we cannot finish all of these in the class, I will provide them regarding the homework. But see this, all of you please focus. This type of questions are very commonly asked in your final exam, not only in our exams, wherever you go, wherever you appear for the computer-based exam, this type of questions are asked these days. So please pay attention. A 19-year-old prima gravida is seen in the outpatient prenatal clinic for routine visit. She is at 32 weeks gestation, confirmed by first trimester sonogram. So it is fairly accurate, this 32 weeks gestation. She has no complaint. She denies headache, epigastric pain, or visual disturbance. So the severe symptoms are absent. She has gained 2 pounds since her last visit 2 weeks ago. On examination, her blood pressure is 155/95, but on retake 10 minutes later, it is back down to 125/72, which is her usual blood pressure. She has only trace pedal edema and a spot urine dipstick is negative. So give me the diagnosis of this case. What is this condition?
Sir, mild preeclampsia.
Mild eclampsia.
Preeclampsia mild, sir, of course.
Is this mild preeclampsia or is this transient gestational hypertension? What is your opinion?
It should
Yes?
be a transient gestational hypertension because there is only blood pressure rises at that time.
Yes, sir.
Yes, sir.
Yes, sir. There is no chance of that producer, so I will also go with transient gestational hypertension.
Yes, sir. And sir, also, sir, we don't use urine test. That's why it's gestational hypertension.
There is no proteinuria basically, sir. That's why.
Exactly. Now you have answering very correctly. Okay, that is the answer. This is called transient gestational hypertension. See that the blood pressure was high just in one visit, and after retaking it 10 minutes later, we asked the lady to calm down and took it again. Now it is absolutely normal, and this slight amount of pedal edema is a normal thing in pregnancy. There is pedal edema in pregnancy, so we consider that as a normal thing. But the important point here is urine dipstick is negative, means no proteinuria. This is not a case of preeclampsia. This is called transient gestational hypertension. Okay, so this is how you have to reach to the diagnosis. Now let's talk about clinical problem solving exercise number 2. So let me go through this and you can solve on your own after we give proper description. This is like a summary of the whole topic. A 21-year-old prima gravida is seen in the outpatient prenatal clinic for a routine visit. She is at 32 weeks gestation, confirmed by first trimester sonogram. So first trimester sonogram is almost, like it is a confirmation of the gestational period. We believe that investigation. Her only complaint is swelling in her hands and feet. So this is the important one. So let me underline these things for you. And this is the way you need to solve the clinical problem. Always, okay, always underline the important points or write the important points and synthesize your diagnosis. That's the way. Otherwise, you will be confused. She denies headache, epigastric pain, or visual disturbance, means it is absent. She has gained 10 pounds since her last visit 2 weeks ago. So the weight gain is excessive. Probably she has retained some of the fluid inside the body. On examination, her blood pressure is 155/95 and remains unchanged on repeat blood pressure in 15 minutes. So this is a clear-cut case of hypertension here. The range is higher than 140/90. She has 3+ pedal edema and her fingers appear swollen. A spot urine dipstick shows 2+ protein. Now combine all these things together and give me the diagnosis.
Sir, may I explain it? Sir, may I explain it?
Yes. So
Preeclampsia.
Okay.
Sir, this is the case of mild preeclampsia because, sir, we have three very important features here. Sir, the first one, sir, we have a sustained blood pressure of more than 140/90 because, sir, for more than 15 minutes, we have a sustained blood pressure here. The second one, sir, we have a urine dipstick of over 2+ protein, so, which also show a case of mild preeclampsia. And the third one, sir, we have the upper extremity edema here, like the finger are swollen. So, there is also third point in. So, sir, this is a confirmed case of mild preeclampsia.
Okay, good. Any other student also want to answer? I'll welcome few of the answers here. Anybody?
Yes, sir. Mild.
Sir, confirm case of mild preeclampsia.
Very good.
Mild preeclampsia.
Due to sustained BP elevation, proteinuria, and edema of the upper extremity.
Very good. So answers are absolutely correct. So see this, all the features are there. Okay. Now the thing is, she is a primigravida, which is a very important risk factors. That is the important point, isn't it? Let's start from the beginning. Okay. Then 32 weeks of gestation that has occurred after 20 weeks. So this point also matches there. There is a swelling or edema of the hands and feet, and there is absence of the severe symptom, and severe symptoms are not present in mild type of preeclampsia. This point is also fitting here. There is a rapid weight gain. This is because of the edema. Blood pressure is not in the severe range. It is still in the milder range. This is another point. She has pedal edema confirmed, okay, with a finger swollen also. And the important thing is proteinuria is also milder. 1+ to 2+ comes under mild type of preeclampsia. So all features are showing mild preeclampsia here. Excellent. So this is the way you need to reach to the diagnosis. Let's move on. Now number 3. See here. A 21-year-old primigravida is seen in the outpatient prenatal clinic for routine visit. Routine antenatal visit. She is at 32 weeks gestation confirmed by first trimester sonogram. For the past 24 hours, she had experienced severe unremitting occipital headache. So this occipital headache is there. Mild epigastric pain not relieved by acetaminophen. So she already took paracetamol, but that pain is not disappearing. And also seen light flashes and spot in her vision. This is called blurring of the vision or the visual problem. So she has, some severe symptoms already present. She has gained 10 pounds since her last visit 2 weeks ago. So there is a weight gain also. On examination, her blood pressure is 165/115. She has 3+ pedal edema. 3+ pedal edema. Okay. Her fingers appear swollen. Fundal height is 29 centimeter. So fundal height roughly matches with the gestational period. Okay. So it is not a very big difference. See there, sonogram is showing 32 weeks and fundal IG 29, so almost there. Fetal heart tones are regular at 145 beats per minute, and a spot urine dipstick shows 4 plus protein. Now combine all things together and give me the diagnosis only. Okay, give me the diagnosis. What is the diagnosis here?
The confirmed case of
Severe
Preeclampsia.
Case of severe
It
preeclampsia,
is
sir.
case of severe preeclampsia with fetal tachycardia.
Okay, so this is severe preeclampsia. Severe preeclampsia. No, fetal tachycardia is not there. See this? The rate is still 145. 120 to 160 is the normal range of fetal heart rate. So all the points are, showing severe preeclampsia because of the presence of severe symptom, because of the rise in blood pressure. See this, diastolic is more than 110, systolic is more than 160. She has pedal edema, okay, and the dipstick urine analysis shows 4 plus proteinuria. So this is a severe case of preeclampsia. Wonderful, very good. Let's go to the number 4. A 21-year-old primary gravida is brought to the emergency department after suffering generalized tonic-clonic seizure, okay, GTCS, at 32 weeks gestation. The seizure was preceded by a severe headache. She lost control of her bowel and bladder. She has gained 10 pounds since her last prenatal visit 2 weeks ago. On examination, she is unresponsive in a post-ictal state. Her blood pressure is 185 over 115 and a spot urine dipstick shows 4 plus protein. What is the diagnosis?
Eclampsia, sir. Confirmed
Eclampsia, sir.
Eclampsia, sir.
Eclampsia.
Confirm eclampsia.
Very good. This is a confirmed case of eclampsia. Excellent. Now, your teacher may ask you certain question here, okay? The teacher asks, give me evidence why this is a case of eclampsia. So let me explain this for the sake of all the student here. Number 1 is the age and primary gravida. Number 2, the gestational period is after 20 weeks, there is 32 weeks. Third, severe headache was there. After that, the seizure started, and the seizure was generalized tonic-clonic seizure. It's called grand mal seizure, which is a feature of eclampsia. And then she has lost control of her bowel and bladder. This is called urinary incontinence, okay, and rectal or anal incontinence. That means the stool and urine cannot be controlled, which is one of the important feature of generalized tonic-clonic seizure. On examination, she is unconscious. This is unconsciousness. That also is very well explained by the grand mal seizure. Look at the blood pressure. Okay, it is high, and a spot urine dipstick also shows 4 plus proteinuria. So what is the meaning? This is eclampsia. Eclampsia means severe type of preeclampsia with generalized tonic-clonic seizure. Now let's move on. Another case. Let's solve it. A 35-year-old multigravida. Okay, she is a multigravida now. A 35-year-old multigravida is seen in the outpatient prenatal clinic for her first prenatal visit. She is at 12 weeks gestation with a blood pressure of 155 over 95. Chronic hypertension was diagnosed 5 years ago, for which she has been treated with oral nifedipine. A spot urine dipstick protein is 2 plus. A recent 24-hour urine collection showed 1.2 gram of protein and a creatinine clearance of 85 ml per minute. Serum creatinine is 1.2 milligram per deciliter. She has no complaints of headache or visual changes. Now, give me the diagnosis. What is this diagnosis?
So chronic
Chronic
hypertension with pre-eclampsia.
Okay,
Superimposed
So chronic hypertension with superimposed preeclampsia. So how do you know this is a superimposed preeclampsia? Which are the point which explains that?
Sir, Sir, urine dipstick test, because when there is two positive, which indicate that there is 1 gram per liter proteinuria.
Okay, that is good. One good point you have picked. Very good. Anything else you can see there? Anything? Any other point?
And sir, also there is visual changes and there papillary edema and headache.
Okay.
Yes, sir.
Good.
Sir, and
Sir, in normal,
12 weeks of
in normal
gestation.
chronic hypertension, sir, there is no visual changes, sir, in normal chronic hypertension. But sir, but when there is superimposed preeclampsia, we will have that visual changes, sir.
Okay. Okay. Now, see there. Now, this is, let me explain it from the beginning, okay? Because most of the students want to know how to, give reason when your teacher asks this type of question. Sometimes your teacher asks questions differently. Sometimes just like I am asking now, give me the diagnosis. Sometimes I ask this question. Sometimes I ask, can you explain the situation? Why your diagnosis is like that? So, okay, so let us learn this. Here is a multigravida and a bit older lady, 35 year. Now she's at 12 weeks gestation. So according to the definition, it doesn't fit into pregnancy-induced hypertension or gestational hypertension because it is occurring prior to 20 weeks gestation. So definitely this is a case of chronic hypertension. There is no doubt about it. Only doubt you have is whether superimposed preeclampsia is here or not. That's it. Okay. Now see there. She was taking nifedipine for chronic hypertension. A spot urine dipstick protein is 2 plus. This is strongly in favor of preeclampsia. Yes, proteinuria is present. A recent 24-hour urine collection showed proteinuria also, 1.2 gram of protein, and creatinine clearance means GFR, glomerular filtration rate, is already dropping to 85 ml per minute. Normal is 120. So it is dropping already. Okay, so already because of the chronic hypertension, there is kidney damage and a superimposed preeclampsia as well. But she has no complaints of headache or visual changes, which are seen only in severe type of preeclampsia. So this is probably chronic hypertension with mild superimposed preeclampsia. Excellent. This is the way. The last one. Okay, so see there. A 32-year-old multigravida is at 32 weeks gestation. So she is 32 weeks gestation now. So already after 20 weeks. At a routine prenatal visit, her blood pressure was noted to be 160 over 105. Previous blood pressure reading were normal. Preeclampsia workup was begun and revealed the following. There is elevated total bilirubin. TSB is high. Lactate dehydrogenase, this is one of the enzyme. Alanine aminotransferase and aspartate aminotransferase, as well as platelet count of 85,000. So what does that mean? There is elevated TSB, there is elevated LDH, elevated ALT and AST, as well as platelet count is low than 100,000 per microliter. She has no complaints of headache or visual changes. What is the diagnosis?
HELLP syndrome.
HELLP syndrome, sir.
HELLP syndrome.
HELLP syndrome.
Exactly. This is a clear-cut case of HELLP syndrome. Though the features of hemolysis, okay, is not given, we don't need all those features together. So there is damage of the liver, which is proven by elevated liver enzyme and elevated total serum bilirubin, and there is low platelet of 85,000. This is a case of pregnancy-induced hypertension. The blood pressure is high, and the lady is later than 20 weeks of gestation. What information more I need? This is a complete description of HELLP syndrome. Okay, so this is the way we have to reach to the diagnosis. I'm sure this type of discussion will help you a lot. Okay, so with this,